So our next speaker is, we mentioned University of Washington with the patient-reported outcomes. Our next speaker is from the University of Washington, and I would describe as a consummate educator. A lot of us who are on this program are great educators, but David Spach, that's one of his primary missions in life, is to educate. And he's been co-chair of this meeting before. He always does a wonderful job understanding not only what providers are kind of up against and what we're all dealing with day to day, but can tease out the key issues that are changing in terms of new data, but also ways to change our practices to improve patient outcomes. So it's a great pleasure to introduce Dr. David Spach. He's going to be talking to us about common complications and sort of anticipating them, preventing them, and treating them if they arise. So David?
Well, it's a pleasure to get to speak to you about this topic today. And my task at hand is to try and bring you up to date on a few issues related to the management and prevention of common HIV-related manifestations. So first of all, I do not have any financial relationships with any commercial entities. And the learning objectives are as follows. Number one, list the preferred treatment for community-acquired pneumonia in persons with HIV. Number two, discuss the initiation of antiretroviral therapy in persons with active tuberculosis. Number three, describe the approach to isolated hepatitis B core antibody. And number four, summarize pneumococcal and zoster vaccine recommendations. So to begin with, let's look at community-acquired pneumonia in people with HIV. I've got several cases here, and this is the first one. A 38-year-old woman with HIV is seen in the clinic in the month of August with a 2-day history of cough, fever, and mild dyspnea on exertion. A COVID-19 test, nasopharyngeal swab, was performed the prior day, and it's negative. She's taking bictegravir TAF FDC, doing well. Recent viral load is less than 40, CD4 count 430, and she has no other medical problems. A chest radiograph shows a focal right lower lobe infiltrate, and she is diagnosed with community-acquired pneumonia. She is not acutely ill, so we're looking at the management in an outpatient setting. So the question here is, based on the OI guidelines, what oral antibiotic treatment should be given for outpatient management of this woman with community-acquired pneumonia? Would it be number one, trimethoprim sulfamethoxazole? Number two, amoxicillin clavulanate plus azithromycin? Number three, amoxicillin clavulanate alone? Or number four, azithromycin alone? The correct answer is amoxicillin clavulanate plus azithromycin. The other alternative that would have been correct here would have been a respiratory fluoroquinolone, levofloxacin, or moxifloxacin. The key point is that macrolide monotherapy, azithromycin, is no longer a correct answer for this. So looking at the OI guidelines that were last updated for this topic in October of 2019, the empiric outpatient treatment of community-acquired pneumonia in persons with HIV has a preferred options of a beta-lactam plus a macrolide, with the macrolide being azithromycin or clarithromycin, or a respiratory fluoroquinolone, levofloxacin or moxifloxacin. The alternative regimen, which is less preferable, would be a beta-lactam plus doxycycline. So the key point here is that macrolide monotherapy is no longer recommended, and the rationale for this is based on data that has emerged from the pneumococcal antimicrobial susceptibility surveillance data. And this is basically showing you a number of antibiotics and the Streptococcus pneumoniae antimicrobial susceptibility to these antibiotics. And as you can see, erythromycin has only approximately 70% susceptibility, or pneumococcus is only approximately 70% susceptible to erythromycin. In contrast to some of the other antibiotics shown here, like 96% with penicillin and over 99% with the respiratory fluoroquinolone like levofloxacin. So really, dual therapy is now what's recommended for community-acquired pneumonia in the outpatient setting. Now let's look to tuberculosis in persons with HIV. So here's a case of a 42-year-old man who's admitted to the hospital with a diagnosis of pulmonary TB. He started on standard RIPE therapy, which is rifampin, isoniazid, pyrazinamide, and ethambutol. He has no evidence of CNS or pericardial involvement. 2 days later, HIV testing results return as positive, and further labs show a CD4 count that's very low at 26 and an HIV RNA that's very high at 236 1,300. So he also has a genotype that's ordered, and that's pending. He started on trimsulfa for PJP prophylaxis. He's tested for hepatitis B and hepatitis C, and these are both negative, and he has no abnormalities on examination other than these pulmonary findings. So the question I'm asking here is 1 week later, he feels much improved and is evaluated to consider starting antiretroviral therapy. So what would you recommend now? Would it be number one, defer antiretroviral therapy until 4 weeks of TB therapy? Number two, defer antiretroviral therapy until at least 8 weeks of TB therapy. Or number three, start antiretroviral therapy now and start prednisone at a dose of 400 milligrams daily. Or number four, start antiretroviral therapy now without prednisone. The correct answer is to start antiretroviral therapy now and to start prednisone. So this is a relatively new recommendation. This was updated in the guidelines in September of 2019. And this is looking at the issues of, first of all, when do you start antiretroviral therapy in people with tuberculosis? And secondly, should you preemptively use prednisone to prevent the IRIS or immune reconstitution inflammatory syndrome? So first of all, looking at when to initiate therapy. For persons with a CD4 count less than 50 and active tuberculosis, it's recommended to initiate antiretroviral therapy as soon as possible, but certainly within 2 weeks of starting TB therapy. If the CD4 count is 50 or above, then initiate antiretroviral therapy within 8 weeks. So it's not quite as stringent as those with CD4 count less than 50. So then the issue of using corticosteroids to prevent TB-associated IRIS. So there are now formal indications for what's known as preemptive prednisone therapy. And this should be offered for patients who have a CD4 count of 100 or lower if they meet the following criteria. They're starting antiretroviral therapy and they've recently initiated anti-TB therapy. They're responding well to their TB therapy, and they do not have rifampin resistance, Kaposi sarcoma, or active hepatitis B virus infection. And those were criteria that were generated based on the study that was performed showing the benefit of prednisone. The dosing of preemptive prednisone, if it is used, should be 40 milligrams a day for 14 days, then 20 milligrams a day for 14 days. And for those of you that are used to using prednisone for acute pneumocystis pneumonia, this is somewhat of an analogous situation where you're trying to prevent a marked host immune response that can worsen the course of therapy. Now, where did this recommendation come from for preemptive prednisone therapy? This was generated from a randomized placebo-controlled double-blind study that was to evaluate prednisone preemptive therapy in persons with HIV who were diagnosed with tuberculosis. And this study was conducted in South Africa. They had to be starting on antiretroviral therapy within 30 days of starting TB therapy, and they had to have a CD4 count less than 100 to be enrolled. The number of exclusion criteria is listed here. Note that the prednisone dosed here was 40 milligrams a day for 14 days and 20 for 14 days, and that was compared with placebo, 120 people in each arm. And what these investigators showed is shown here is that if you look at the incidence of paradoxical TB-related IRIS, you can see that those individuals who received prednisone, shown in the blue bar, had a statistically significant lower risk of paradoxical TB IRIS than those who received placebo, which is shown in the brown bar here. And the p-value for this is p is 0.03. And note that in this study, the prednisone treatment was not associated with an increased risk of severe infections or cancer, so there was an upside and essentially no downside for this. And that's what led to this new recommendation. Now, for this man with pulmonary TB on RIPE, which antiretroviral regimen would you recommend? Would it be number one, bictegravir, tenofovir, alafenamide, emtricitabine? Number two, darunavir, cobicistat, tenofovir, alafenamide, emtricitabine? Or number three, dolutegravir, rilpivirine at the fixed dose tablet? Or number four, dolutegravir at an increased dose of 50 milligrams twice daily, plus tenofovir DF emtricitabine? So the correct answer here is number 4, dolutegravir twice daily plus tenofovir DFM tricytamine. So the key point of this case is to illustrate there are significant drug interactions you have to deal with when someone is on RIPE. So RIPE includes rifampin, and rifampin is very problematic. And as you can see here, for the nucleoside reverse transcriptase inhibitors, they're all okay, but you should use caution with TAF. For the non-nucleosides, efavirenz is the only one that can be used, and it's recommended to use it at standard dosing. For the protease inhibitors, none of them are recommended. And the integrase inhibitors, either dolutegravir increased dose 50 milligrams twice daily, or raltegravir 800 milligrams twice daily, increased from the usual 400 milligrams twice daily. So there are options to use, but they're very limited if you are using rifampin. So now let's look at some immunization issues in persons with HIV. First of all, with hepatitis B vaccine. So who should be screened for hepatitis B? And for persons with HIV, essentially all persons with HIV should be screened for hepatitis B with the following tests: hepatitis B surface antigen, anti-HBs, which is antibody to the surface antigen, and anti-HB core, which is antibody to the core proteins. So here's a case looking at the issue of how do you address isolated hepatitis B core antibody. This is a common issue that comes up in the clinic. A 28-year-old trans woman, the preferred pronouns are she, her, hers, recently moved and has a visit to a new clinic. She's taken dolutegravir plus TAF FDC for about 6 months. Initial clinical labs show CD4 counts very high at 824, suppressed viral load less than 40, hepatitis B surface antigen negative, anti-HBs negative, and anti-HBC positive. So she has isolated hepatitis B core antibody, and she'd never received hepatitis B vaccine. So the question here is based on recommendations in the HHS-OI guidelines. What would you recommend now to address the isolated anti-HBC or isolated hepatitis B core antibody? Would you, number 1, give 1 standard dose of the hepatitis B vaccine and check a titer, an antibody titer, in 1 to 2 months? Number 2, give the full 3-dose series of a standard dose hepatitis B vaccine. Number 3, check hepatitis B DNA level and then go from there. Or number 4, she should be considered immune and no further action is needed. The correct answer is actually number 1. Give 1 standard dose of the vaccine and then check an antibody titer. And this is now something that there is clear guidance in the OI guidelines, and this was generated and last updated in November of 2018. And basically they address this issue specifically. What do you do when somebody comes in and they're isolated hepatitis B core antibodies? So the recommendations now are to give a single dose of the hepatitis B vaccine and then wait 1 to 2 months after that and then check a titer. Now, what's very interesting is the next recommendation is that if the hepatitis B antibody titer to surface antigen, anti-HBs, is at least 100 or greater milli-international units per milliliter, they are considered immune to hepatitis B. But note here, the cutoff or the titer used here is 100 and not 10. We're used to using 10 as a standard titer for gauging immunity to hepatitis B. So this is a very specific recommendation for addressing isolated antibody core, people with isolated antibody core. Now, if you look, if it's less than 100, the recommendations are then complete the hepatitis B vaccine series. So they would need 2 more doses for standard hepatitis B vaccine series, and then check a titer after that, and then go from there. And consider re-immunizing them with double dose or additional doses if they don't respond to this full vaccine series. So this is a sort of different situation than I think most of you are used to seeing, where the cutoff is 100 and not 10. Now, where did this cutoff of 100 come from? It came from a French study published in 2016, and they specifically looked at this issue of people with HIV and isolated anti-HBC. So what they did is they were really looking at, if you gave them a booster dose, did people have a good antibody titer that persisted for 18 months or longer, or longer than 18 months if they got the booster dose? And what they found was the following. 100% of those people who achieved a titer of 100 or greater after getting a booster actually did well, and they had sustained immunity. But note that only 23% of those had sustained immunity if they had a titer of 10 to 100 after the booster. So that's where this cutoff of 100 came from, because essentially if you're between 10 and 100, you don't have good sustained antibody responses if you are isolated core antibody. Now, the concept of this is that antibody to hepatitis B core is a peptide that's inside of the hepatitis B virus, and the immune response to hepatitis B core occurs pretty early at about 6 weeks after infection. It's a very robust immune response that persists very consistently. Now, in contrast, if we look at the scenario like the individual that I presented in this case, where someone could have been infected with hepatitis B, resolve the infection, their core antibody would remain robustly high, but their surface antibody can wane over time. So if you look at the far right portion of the graph, that essentially illustrates the scenario we're in this case, where core antibody is remaining positive, surface antibody has waned, and the person's DNA is not detectable. There's one other scenario that gets brought up, and that's rarely these individuals with isolated core have low levels of hepatitis B circulating without positive antigen. So hepatitis B surface antigen is shown in the purple curve. That has resolved and is not positive. But in this example, an individual far out from infection has persistent hepatitis B DNA levels. This is not a common scenario. This is a situation you could have isolated core. But note that in the modern era, when most people are taking TDF-FTC or TAF-FTC, you're very unlikely to see this specific scenario. Now let's look at pneumococcal vaccine. So to remind you, there's two different types of pneumococcal vaccine we use in clinical practice. First of all, there's the conjugate pneumococcal vaccine known as PCV13. And this is basically generated by taking a piece of the pneumococcal polysaccharide capsule and then conjugating with a protein that does a better job essentially of recruiting the immune system to respond to this polysaccharide capsule. So this is the PCV13 conjugate vaccine. Now, the polysaccharide vaccine, which is known as PPSV23, similarly uses the polysaccharide capsule, but without any conjugation. Now, the standard recommendations for pneumococcal polysaccharide vaccine are to give people the conjugate vaccine first, and then to wait approximately 8 or 9 weeks after that, and then administer the next dose of or to give a dose of the polysaccharide vaccine. And then all subsequent doses of the polysaccharide vaccine should be spaced 5 years apart. And in total, the most that someone should get are 3 doses of the polysaccharide vaccine. And again, every time somebody gets polysaccharide vaccine, they should be spaced 5 years apart. The last one should be given at the age of 65. And again, the most total would be 3 for the polysaccharide vaccine. Now, the timing of the pneumococcal polysaccharide vaccine is different than the timing for the conjugate vaccine. The conjugate vaccine, PCV13, should be given regardless of the CD4 cell count. The timing of the first dose of the polysaccharide vaccine is straightforward if the CD4 count's 200 above. You just go ahead and give it at least 8 weeks after the conjugate, so the standard recommendation. However, if the CD4 count is less than 200, there are 2 options. You can defer and wait and give the dose of the polysaccharide vaccine till the CD4 count's 200 or greater, and that's actually probably the preferred thing to do, or you could just go ahead and give it at least 8 weeks later. And I think most experts would wait until the CD4 count's at least above 200 to give that first dose of the polysaccharide vaccine. So now let me finish on zoster vaccine. So the herpes zoster vaccine, we have 2 types now. There is, as shown on the left, the zoster vaccine live, which essentially is taking the native live varicella zoster vaccine and attenuating it. In this particular type of vaccine, individuals theoretically can develop a disseminated or live infection. On the right is showing you the recombinant zoster vaccine, or RZV, and this vaccine is generated from using a glycoprotein off of the surface of the varicella zoster virus, and then combining this with a very potent AS01B adjuvant. And that adjuvant really is what's enhancing this major immune response and is responsible for the improved vaccine take rates with the recombinant zoster vaccines. It's also probably responsible for some of the increased side effects we're seeing, especially local reactions with the recombinant zoster vaccine. So now, if you're looking for recommendations from the 2020 ACIP recommendations on using the RZV vaccine in persons with HIV, you're just not going to find them. This is illustrated by a direct screenshot of the table from the guidelines. The HIV recommendations here to the far right, and they divide them CD4 count less than 200 or above 200, and then the RZV is shown down on the bottom. And you can see that if you track these down together, there's essentially a gray box there, which means there's no recommendation, not applicable. So unfortunately, we don't have any recommendations for or against using this vaccine in people with HIV from the ACIP. And this has created some issues in terms of vaccine reimbursement and insurance. But I do want to point everyone to the OI guidelines because they have clear recommendations for using the zoster vaccine in people with HIV. And this can be pointed to if there's any issues for reimbursement or from insurance companies. So the preferred recommendation in people with HIV is to use the recombinant zoster vaccine, RZV, anyone 50 years of age or older. And as a reminder, this is 2 doses. They should be spaced out 0 to 2 to 6 months. And because of sort of the COVID situation, if your second dose has been delayed, not a worry, just go ahead and give it when you can. Ideally as soon as you can, but it still should only be given 2 doses total. The alternative is the zoster virus live vaccine. Again, anyone 50 and older, this is the alternative. We do not want to give this to people with CD4 count less than 200. It's a live virus vaccine. So it should only be recommended in people with CD4 count of at least 200. And also the amount of varicella zoster virus in this is very high. It's about 14 times higher than what you see in the standard varicella vaccine. This is only 1 dose. So now, let me just summarize then the top 5 key points that I've tried to emphasize. First of all, for community-acquired pneumonia, the recommendations now are either dual therapy with a macrolide beta-lactam or a respiratory fluoroquinolone. Key point is macrolide monotherapy is not recommended. Starting an individual with on antiretroviral therapy who has active tuberculosis, we now should be offering prednisone if the CD4 count is less than 100. This is to prevent TB-associated IRIS, and this is also assuming they meet the criteria that I listed out earlier. For isolated hepatitis B core antibody, start with the booster dose. And also remember that your immune titer you're looking for is going to be 100, not 10. In terms of the pneumococcal vaccine, remember that with the pneumococcal conjugate vaccine, the PCV13, do not delay that if the CD4 count is less than 200. And last, for the zoster vaccine, give the recombinant zoster vaccine to all individuals 50 years of age and older. Thank you. I'll now turn to the question and answer section.
All right, great job, David. Welcome. It's time for the Q&A now. Let's start off with just a general comment, perhaps, about OI guidelines and what do you see coming up new on the horizon?
Great. Thanks, Mike. Well, one of the things that I want everybody to know about is that sometime maybe in the next 4 or 5 days, the OI guidelines are going to have a complete update and revision on all the vaccine recommendations. So I kind of held off as long as I could, but they did not get pushed out before this talk. But I know from someone on the committee for this. So for everybody that follows the vaccine and has a lot of interest in this, please check the guidelines in about a week or 2 and look and see if you see it's supposed to be a complete revamp of the section. So it should be very helpful.
Yeah, you can't give us a preview?
No, I don't. Actually, I don't know all the things that are going to be. I know that there'll be that there's going to be major revisions. That's all I was told.
Okay. Well, all right. We'll keep our eye open. Let's talk a little bit about the hepatitis B story. There's a bunch of questions here about false positive core antibodies, or what should we do if the hepatitis B surface antibody between 10 and 100 and that type of thing in a booster dose. Can you just kind of do a recap of that for us?
Great. Let me try and go through this. And I know that recommendation, just looking at the responses on the questions, I think these guideline recommendations for how to approach Hep B core antibody is very different than what people are currently probably doing in their practice. And I think there is some logic behind these recommendations in the OI guidelines, but a couple things to take into consideration. Yes, you can get a false positive hepatitis B core antibody. That's less common now with the current testing that's used, but that is one of the causes. I actually didn't present that, but that's definitely on the list of things. Now, again, you should be able to sort that out once you do the booster dosing, and sometimes they call this booster dose a challenge dose. That's essentially you're looking to see, did the person have the infection before, and are you going to boost their immune system immediately with that one isolated dose? Now, what do you do if it's between 10 and 100? The OI guidelines say that if it's not above 100, you should complete out that full hepatitis B vaccine series. So the current recommendations are to go ahead and administer the full dose series if they don't reach that 100. And again, all of this came about from this one study where they saw that if you kind of fell anywhere below 100, and they did look at people that fell between 10 and 100, when they looked 18 months later, these people did not hold on to good surface antibody titers greater than 10 at that point. So, when they looked 18 months later, they didn't feel like they were protected. So that's where all of these recommendations came from. And again, the reason there, and Mike, I'll go ahead and I'll address the question about the HBV DNA, because that's kind of right in the same lines. So again, it is felt, especially from the approaching these isolated core, that the approach isn't as clear just looking at if they have a positive HB DNA, but probably more importantly, since I would say, more than 80 to 90% of people we're seeing now, they're on chronic TAF FTC or TDF FTC, and most of those people eventually are going to have an undetectable HBV DNA. So it's really, if you get a negative test, you're stuck there. So I think that was the multiple reasons why we no longer see the recommendation of screening with HBV DNA first.
Right. And we'll wrap up hepatitis here with this last question I have, and that is, if the patient's struggling getting a titer, is there advantage? I think you may have mentioned this, to the I hate using trade names, but the HepSlav vaccine that has a little different adjuvant.
Yeah. So one of the issues that comes up over and over and over again in the clinic is, what do you do when someone doesn't respond to a full dose series? And there are clear guidelines in the OI guidelines now, and I don't know that I 100% agree with them, but I'll tell you what they are. The recommendations and guideline are, if someone doesn't respond, you can do the exact same thing again and give them a standard 3-dose series with our currently recommended single antigen doses. That's one recommendation. The other recommendation is to double the dose, and instead of giving 3 doses, give 4 doses. That's what I've historically done in my practice. If someone doesn't respond, I try something different. I look at 4 doses and an increased dose. Now, for those of you that are familiar with HepSlav, which is got a completely different sort of hyper adjuvant that gives these great immune responses. There's an ongoing large study called the Beehive study, where they're actually looking at this in specifically people with HIV who did not respond to the initial doses. I'm very enthusiastic about enrolling people in this trial, because if it works and you could use the one caveat is that in most of the arms of the study, they're looking at 3 doses of the HepSlav, which, when people who don't have HIV, and initially it's a 2-dose vaccine, which is really convenient and makes it much more of a real world, sort of like using, PPD testing, versus an IGRA, that, the IGRA is just so much more practical that clinics have shifted over to. Same thing with that HepSlav. More of the issue now is cost. But for those of you that follow this, the Beehive study, if you get a chance to enroll people in it, it's looking at standard dose vaccination for failures versus using this, the HepSlav, which has this different adjuvant in it.
So it's a little bit ahead of the curve. We'll maybe update that next year.
We will update it next year, and there just isn't the data yet to know whether or not that's the right thing to do. But I think it's very promising, because the reason the person's asking this question probably is that we look at all the data with the Heplisav, and you clearly get better immune responses. If you look at immune competent people, and even in some limited data with people with HIV, the immune responses are definitely better.
So there'll probably be some honey from the beehive by this time next year.
Hopefully so.
Okay,
Hopefully
moving
so.
on. How about TAF with rifampin and rifabutin?
Okay, this is a really important question, and there are emerging data. So I would say about 2 years ago, TAF was considered a no-no with rifampin or rifabutin, and now people are saying yes, you can go ahead and give it with caution. So I actually think more people are getting comfortable with TAF and rifampin or rifabutin, and I would feel comfortable with that. I think the point of this comes up when you're trying to find something, a short course therapy for people with a positive PPD, and you're looking for the 3-month, the 3 HP regimen, which is going to be the rifampin, and that's where this comes into play, where TAF is basically there's issues with that, and then there's the 4-month rifampin, where now we're being able to say we can move forward with that with caution at this point. So I think it's emerging that with rifampin, TAF is considered acceptable. With rifampin, I think most experts are still not recommending using TAF with rifampin.
Okay. There's a question about pneumococcal vaccine. If they've had the PPSV23, let's say 3 doses before the age of 65, do you give it again after 65?
So they probably shouldn't have had 3 doses before 65, and there aren't clear guidance for this, but I would say yes, as long as you waited 5 years. So there are a lot of different scenarios. Let's say that you diagnose somebody with HIV and they're 62 years old, and you give them their conjugate vaccine, you wait 8 weeks, you give them their first polysaccharide, and let's say they're 62 years old. You'd wait 5 years, you'd give them the polysaccharide, the PPSV23, then they're done. So that person only got 2 total. So and the person that you described, I would go ahead and give 1 more dose at age 65, because I think there's considered this extra value of immunizing people over the age of 65.
Yeah, and I think it's just such a moving target, because these guidelines are changing. We look forward, like you said, in the next couple of weeks, maybe it'll change a little bit or be a little clearer for what to do there. There's a question here about Hep C screening. And you've got somebody, they're up to date on their Hep A, their Hep B vaccinations. And then the question is about annual Hep C screening. Let's say they're antibody negative for Hep C. Do you check that annually?
Yeah, that's great, Mike. So the guidelines now, the guidance really give us clear recommendations on that. For people who have ongoing risk, who could be persons who inject drugs and men who have sex with men, they should get annual screening for Hep C. We do it in our clinic, and we have picked up a number of people where MSM was their only risk factor for hepatitis C, and we've seen it. So I highly recommend that for people doing this now. And I think for those of you in your general practice, you may have seen the CDC recommendation that rolled out earlier this year, that we now have this widespread screening recommendation for hepatitis C, analogous to what we had back in 2006 with HIV screening recommendations. So now in your general patients outside of the HIV world, there's now sort of universal screening one time recommended for hepatitis C. So that's really important. Mike, the hepatitis C did raise a question for me, and raised one of the other issues that somebody's asking about reactivation, and whether or not the core antibody, those people are still at risk for hepatitis B reactivation. So I would say if you're treating a person for hepatitis C, we have learned that those people who have hepatitis B surface antigen or core antibody do have a risk of reactivating. So that's a person that you would want to track if you started them on hepatitis C with a direct antiviral DAA therapy. Now, this day and age, again, most people are going to be on TAF FTC or TDF FTC. So you kind of have that blanketed anyway.
Yeah. Well, that's a good, unfortunately, we don't have time to get to all the questions, and we'll try to figure out a way to post questions and answers on the website after the meeting. But thank you so much, David. Great job, as always. And I think the last topic we were just talking about is a wonderful segue